Hello, everybody, and welcome to today's IFAM webinar. I'm Ron Ackerman. I direct the Institute for Public Health and Medicine. Before I introduce our presenter for today, I want to remind each of you that we encourage any member of the listening audience to submit questions to our presenters at any point throughout the presentation. To submit a question, simply click the Q&A button at the bottom of your Zoom screen. At the end of the presentation, we'll move through each of the questions, time permitting. Today, I have the pleasure of introducing Dr. Andrea Graham, who is Assistant Professor of Medical Social Sciences and Preventive Medicine at Northwestern University, Feinberg School of Medicine. Dr. Graham is a doctorally trained clinical psychologist who leads research that focuses on designing, optimizing, and implementing how implementing digital health interventions. She's interested in understanding how evidence-based interventions are adopted in practice settings and in the effects of different strategies for training clinicians to deliver evidence-based interventions for mental and behavioral health problems. Dr. Graham's presentation today is titled Optimizing Engagement and Implementation Through Design for Health Interventions. Andrea, we're so excited to have you with us today, and I turn the microphone to you.
Thank you, Rod. I am so thrilled to be presenting and for this opportunity. Thank you. I'll dive right in. So my program of research has focused on increasing access to high quality healthcare for primarily mental and behavioral health problems, and primarily focusing on using scalable interventions. And in particular, my work has really focused on four sort of broad domains of thinking about interventions themselves, thinking about implementation and the policy surrounding those interventions, screening for mental health problems, as well as training. And in particular, to realize that vision of increasing access to care, my work is primarily focusing on digital interventions. Today, I'm going to talk a lot about digital tools, but also a lot of this focus really extends beyond just digital, but health interventions in general. And I'll speak to some of those relationships. But the primary tool that I've been using is digital as a means to increase access to care. And in particular, this is a model that we published a few years ago in thinking about sort of a person who has mental health problems, all the barriers that come up along the way between someone having mental health problems and actually improving their mental health. And we sort of group this into four buckets along a process of people need to know that care is needed. They need to then want to actually get into care and then subsequently get the care and actually stay in care. And each of those steps has several barriers from both patient side as well as system side that can get in the way of achieving that goal. And the reason I really turned to using digital tools is they offer opportunity to solve a lot of those process barriers at multiple steps of that chain. And so in terms of improving that, knowing care is needed, wanting care, getting it, and then staying in care. And in particular for digital, but I think we have this applies really broadly to just health interventions in general, but in digital, the disruptive innovation, sort of the real game changer of digital tools is the ability to extend treatment beyond in-person services into the fabric of people's lives. The implication of that is if these tools are not engaging, though, people will stop using them. And the reason that's a problem is really essentially these tools then, quite frankly, have to be engaging in order to have clinical impact. And the same can be true for evidence-based interventions in general, just whether it's digital or non-digital. So if people don't engage with our interventions, they're not going to be using them. And so they need to be engaging in order to have clinical impact. So even our best tools, our most potent clinical services, if people don't use them, it doesn't matter. So why do I care a lot about engagement? Engagement's a real problem. So when health interventions have moved from research settings to real world settings, implementation has frequently failed, where we see low rates of use and retention among patients of these tools and evidence-based services and failed integration within their systems of care. And really, this design chasm, I would say, is that it's because interventions are often not designed for the users and contexts in which they will be implemented. And more specifically, the disconnect is that, as I mentioned, these interventions need to fit into the fabric of people's lives. And more specifically, I mean that we need contextually relevant care. So interventions that are better matched to patients' need through greater personalization and precision, as well as better matched to practitioners' workflows. And you'll see in this talk, I think a lot about clinical settings and healthcare settings, but this could be sort of any kind of setting. It doesn't need to only be within healthcare, but sort of the people who are actually delivering these tools and services, we need to be making sure that our interventions are matched to the workflows of that setting in really pragmatic ways. And as you'll see as the focus of my talk, design can help achieve those goals. So my goal for today is to talk about designing interventions to both meet users' needs and subsequently to integrate into workflows. And let me explain as an example of this disconnect, sort of the problem that we've seen with mental health apps to date. So typically, and this is thankfully gaining more traction as not being the case, but typically what's happened is that we've simply translated face-to-face treatments to a digital format, where typically digital mental health interventions have been designed where they rely heavily on psychoeducation, where they require 30 to 45 minutes of use per week, and typically for at least 6 weeks or more. And you can imagine that engagement subsequently is challenging in these kinds of tools when they're done digitally. Let's think now about how people use apps. So this is a schematic of my route on Google Maps between home and work. So each morning when I'm driving into work and not living in our virtual world, I open up Google Maps, I figure out if I'm going to take, for those who are familiar with Chicago, either Lakeshore Drive or the highway, and then I close Google Maps. And when I leave for the day, I then open it again and figure out the way home and close it. And so essentially it's about 30 seconds twice a day, and it's really a single purpose in a short burst of time, sometimes frequently throughout the day, with a focus on action more than psychoeducation, where I'm really turning to this app to help me achieve a goal and then leaving the app. And that is a really different way that we use apps, distinct from maybe how they've been designed to date. And so colleagues and I at the Center for Behavioral Intervention Technologies here at Northwestern, we developed a conceptual model where we say actually what one way in which we can achieve changes in symptomatology and help people clinically improve is by making sure we're designing these services to be really engaging, not just objectively, sort of how often people are using it and logging in or having contacts with the healthcare system, but actually really thinking about the subjective, the user experience. So is this an intervention that's useful to people? Is it usable, easy to use, easy to learn? And importantly, is it satisfying? Does it actually create a user experience that makes people want to use this tool, subsequently leading? Because if they then want to be engaged with it and they do then engage with it, that's really what's going to help lead to changes in clinical outcomes. And so the approach that I've been using, and that's sort of been the disruptive innovation of my own sort of research, is actually thinking about the role of human-centered design or user-centered design as a process. And this is one model that we published on, showing the user-centered design process and thinking about how it can be designed, applied to designing technologies and or innovation, so solutions in general to meet people's needs. And this is the figure. It shows the stages of the process where we go through multiple stages to design a tool. What's sort of not in the figure, but really needs to be centralized is that the user is really at the center of this entire experience. And by user, I mean someone who's going to be actually using this tool or impacted by it. So we're sometimes designing not just for the individual themselves, but for the others in the socio-technical system who might be impacted by this tool. And you could see that there's several phases where you begin by really understanding the needs, goals, and preferences of the users and stakeholders and contexts in which these kinds of solutions are going to be implemented. And from there, by really getting a good understanding of what those needs are, pain points, problem areas, and goals, you can then generate solutions towards that, generate ideas towards that solution. My favorite part of this cycle is that in the world of prototyping, where you're creating iterative options of how you might create a product or create a workflow in order to solve that idea. And what I love about prototypes is anything can be a prototype: Post-it notes, sort of a PowerPoint slide, things. It doesn't have to be a fully functioning digital tool in order to be a prototype. And what's most sort of, to me, impactful is learning that the moment you put things in front of users, you're going to get a lot of feedback that's going to really help you think about sort of the stage of change that you need to then be doing. So within this model, prototyping and evaluating, where you're iteratively testing these prototypes with stakeholders and actively getting their feedback on these design options is really imperative. And so you might go through several iterations of this subset of the model before you even go from for example, with technology, before you even go to the software programmers about what you're going to develop, that you spend a lot of upfront time, designing the tool before you then develop it. And then subsequently, the quote unquote last stage of the model is then validating your product in practice. So that's sort of where a lot of us as clinical scientists live in terms of doing a controlled trial and really trying to validate that tool. I think what I've also come to really appreciate about the role of design is that it really doesn't stop there. And so actually, typically, then you're going to learn a ton more from your users and really revisit the investigate phase again, and the model might continue on. And so why have I really embraced using these design efforts in my work? And I think where they have such advantage to the work we do and how we design tools and implement them in systems is because it really enables rapid learning. So there's a lot of design methods in this review paper where I published this model. We go through several of these methods, most of which can be implemented relatively quickly. And doing so is actually going to save money and rework down the line. And so in particular for technology, but this is the case across the board, many problems are avoidable if given adequate attention. So if you think about sort of reworking this before you build it and you actually spend time before you engineer this tool with significant software development resources, that's going to save you a lot more money if you've honed in on what you want to build before that. So there's really terrific advantage of upfront efforts, but you can also think about if you go into a care setting and you do one, an important implementation strategy is sort of small acts, small tests of a strategy of the intervention and its deployment. That's going to allow you to see how it's working, sort of kick the tires and figure out what needs to change before you do a full scale rollout. So this is really setting the stage for the first portion of my talk today, which is thinking about designing interventions to meet users' needs. And in particular, I'm going to talk about an example from my Career Development Award where I've been designing a mobile intervention for binge eating and weight management. And in particular, I love to show this figure because it's incredibly busy and hard to digest. And while I think it has a lovely layout, there's a billion bullets and it's just a lot to take in. And the reason that's really important is once I got my grant funded, I showed my intervention layout, what sort of this graph is showing, to my HCI mentor, Madhu Reddy. And he said, no one's going to do your app. I said, what are you talking about? These are all the important things like we need to cover. He said, this is too many bullets. It's way too big. I mean, and this was the schematic of what I wanted included in the app. And he said, no one's going to do it. It's too much. He said, in fact, what do the users want? And I said, well, I'm a clinician. I've treated lots of people with binge eating. Like, I know what they want. I know what's necessary. And he said, that's the problem. Sort of what you think people might need may or may not be how people engage with their phones and with an intervention, and really starting with the drawing board, going back to the drawing board to understand what it is that users need. And that's really been sort of the core component that I've really embraced, is that as a behavioral scientist, we might know some of the key principles that need to go into an intervention. How that's delivered to individuals is really where I think sort of the art of design and implementation science is. And so what I've done is I've gone through the phases of the model where we've done lots of different design activities across the phases of the design model. And I'm currently near the end of my pilot trial, which is amazing. And my target end is 72. We've officially enrolled our last person. I want to show the disconnect. We've done design activities with 137 individuals to date. And the pilot trial was 72. And so it's literally double the amount of work that we've really put into design, because it's that important to, I think, really understand the needs of this population and how we get there. And I want to call out a big shout out to my team. You could see we've put, I have several references down at the bottom, because I've found that thankfully it's gaining a lot more traction, but in the clinical science literature that people are not using these design activities. So I'm just thrilled to work with such a great team who's been really invested with me in wanting to disseminate sort of how we apply these methods and think about designing tools and the implications of that work. And so where did we start with designing an intervention? Essentially, we asked this initial question of, how do binge eating and weight impact your day-to-day life? And the reason that's important, not because I want this talk to really be about binge eating, but really to demonstrate, in order to design contextually relevant services, we needed to understand what are the contexts in which these problems impact their day-to-day lives. Like, where are the pain points for people where these health problems are really creating problems in day-to-day contexts? And what did we find? So the early design work really brought to light that people present to treatment with wide variation in past intervention experiences, interests, and needs. And perhaps not surprisingly, but it was an incredibly powerful reminder, 100% of people we've interviewed have endorsed past attempts to lose weight, and 91% have endorsed past attempts to stop binge eating. I don't know if those are empirically supported treatments that they've been involved in with licensed clinicians. It doesn't matter. What it means is people are not coming into a new app naive to some of the behavior change strategies that might be asked of them. And yet they're still struggling with this problem by meeting criteria to be able to come into an app for binge eating and weight management, suggesting we need to wrap our head around a tool that could meet people at very different stages of a journey in terms of where they're starting from and where they're trying to go. If you're hearing that and thinking, oh my God, where do you get started? That's exactly right. I had no clue. And so it's sort of then, how do you design for many people with a single tool? That's a real interesting challenge. And so we then had the idea of then saying, like, well, what about letting users decide that, right? So what if we actually have user-directed behavior change? And we did a prototyping study of a proof of concept for 1 week, where we said to people, what do you want to work on? We gave them 20 different options, bucketed into these 5 different clinical targets that I felt are really impactful for the clinical area. And we said, go do it for a week and report back. We gave 0 feedback during the course of the week. We just said, go do it for a week. And what was incredible was what then happened. So how did it go? 82%, the vast majority said, you know what, this went as I thought it would. It went sort of planned or somewhat as planned. Only 20% thought it was not exactly what they were expecting. Did it help? 82% said yes, they thought it helped for the week. Would you keep it going? 86% said yes. And did it work? To be very clear, we weren't like expecting to see changes. It was only 1 week, but we actually saw average within subject reductions in weight and binge eating over this first week of just letting people do what they wanted within a constraint. And so consequently, we really went from design to development and developed my FoodSteps, we call it FoodSteps, the FoodSteps app, the program. And we really went from the double diamond model of where we tried to then really discover what was the problem area for people and really understanding the context in which they could have health, their health problems can create challenges for them. We then defined sort of how we wanted to go about the behavior change. I then mentioned we did, sort of all this work before turning to development, and now we're in the process of delivering it in a trial. And so essentially, what can you work on in FoodSteps? I'm showing you these slides not because, again, you may or may not be invested in binge eating, but really to think about the way we then approached how do we do sort of person-specific behavior change and empowering individuals to change their own behavior in a simple way. So in a way that's really usable. And so essentially each week people report on 2 metrics. What did they weigh and how many binges did they have? They pick a challenge area. So every week they see the same sets of challenges. They're given an array of options, but they choose, and then they set a goal related to that. And they pick days that they want to practice. And over the course of the week, they mark off with a star rating whether they practice their goal. And so it's really about empowering individuals to say, like, where are you at this week? What do you think is going to be helpful, but still giving swim lanes and sort of guidance on the types of topic areas that are really important. And then individuals are assigned a coach to provide supportive accountability and helping them stick with the program and thinking about their goals and helping shape those goals. Because one of the things in that proof of concept trial we saw is if you give people no feedback throughout the week, that's not exactly setting them up for success. And so can we intervene more quickly and helping them rethink their goal so that it's not too lofty, not enough, and really helping them shape a goal that would meet their needs. So how's it going? This is preliminary data because, as I mentioned, the trial's still in progress. But I would say thanks to all of our design efforts, I would say quite impressively, we've designed a tool that's really engaging. So users are completing 80% of the program on average. and they're having really high compliance. So they're picking targets, meaning they're like picking a challenge area and setting a goal and indicating their metrics, their assessments on 94% of the sessions that they complete. And sort of an opposite to sometimes what we see with apps is that even though this tool is quite engaging, I do think we have an opportunity to have greater precision in overall change in clinical metrics. But what an amazing place to be starting from, where we actually have a tool people would use. I think we know what the precision needs to be in terms of how to get people to change their behavior. It's actually doing it in a way that they're going to find inviting. So to me, I feel very excited and hopeful about our potential to add more potency into a tool that's actually starting out as engaging. One of the ways that we're also thinking about supporting behavior change that we've done some proof of concept design work, but haven't built in yet is there's some awesome work. For example, this paper by Sean Munson, a colleague at University of Washington, where people are thinking about, well, if we're trying to support individual behavior change, it's really important to understand and elicit individualized goals and help people think through sort of what goals are they trying to achieve, and then designing tracking systems, monitoring approaches that help people achieve the goals that they want to do. And so what we then did is we tried to understand self-monitoring preferences and behaviors in an app like FoodSteps. And essentially, again, we really thought about how can we do sort of a proof of concept understanding of this in terms of understanding people's self-monitoring preferences. And this is a hot off the press, just accepted paper by a student of mine. And I just think the results are, which will be on the next slide, are just so interesting. So essentially, in the first week, we said, what are the kinds of things you'd want to monitor in it that would be sort of important to you to have change that you'd want to monitor if you came into an app for binge eating and weight management? And so we surveyed the group. And then in weeks 2 to 4, we randomly assigned people to 2 different conditions. So we either said, okay, well, your condition, you're just going to monitor weight and binge eating, sort of as you saw what I'm already doing, what we call the clinician determined monitoring. And then in the second condition, you're going to be actually doing those same 2 metrics plus another one that you choose. So they get to decide and drive that boat. And we said, we want you to do this for 3 weeks. You're going to do it twice a week and you'll just report back to us. And they didn't receive any other intervention except just reporting on how it was going. So how did it go? So essentially, what do people want to monitor? This is like my favorite, 116 different things, 116. And we group those into 12 themes. And so you think about a tool, how in the world would we design something that gets people to do 116 different things, or even 12, knowing you want people to be sort of doing this on a regular basis, thinking about burden, thinking about people's own goals. And we're going to talk about I'll mention sort of how we're conceptualizing this, but it really drove to light again, this idea that people come in with lots of different interests and goals. And we need to think about how to, I think, empower individuals to be engaged in their care. So what do people choose to monitor? So in the group, who was assigned to pick something else, there was 24 people and they chose 41 different metrics. And I'm laughing because we actually told them to pick one each. So we should have seen 24 and we instead got 41. Over the course of those 3 weeks, despite being told that they would monitor the same thing, 50% changed the metrics that they were monitoring over those 3 weeks. And in the condition where they were told what they should monitor and not anything else, 96% qualitatively reported to us that they monitored additional metrics. And I'm laughing because essentially the reviewers came back and said of this paper, like, oh, your manipulation failed. And I thought, well, no, it's the opposite. Like, we actually got a lot of insight into what people are doing in the real world and the ways in which our currently designed interventions are not then meeting their goals. Because in this latter option where we gave them preset things, they're saying that in their day-to-day lives, they ended up doing all kinds of other stuff that we hadn't accounted for. And importantly of note, we didn't see any difference in satisfaction or compliance between the groups, meaning it was actually ceiling effects. Everyone was satisfied and had high compliance. And so the implications of this, I think, is really to then think about maybe designing an individually customizable monitoring option. So providing the preset options that we think about for measurement-based care and making sure that we're quantifying sort of the types of targets that we want people to hit, but allowing people to monitor their own things while also providing guidance around, thinking about the 50% who switched, like when we want people to switch their metrics, when they providing better design around sort of what it means to do individually based care and how they can sort of learn for themselves when it might be time to switch, when they've accomplished certain goals, et cetera. So I just loved these findings. And so just to close out sort of where I'm going next with this work is now trying to sit at the design crossroads, which is where we've been getting lots of feedback from users in the trial. We ask every user for feedback. And really, we're at sort of a lot of conflicting design ideas for next steps. So one idea is, how do we sequence these challenges that people pick week to week? Should they get the same things? Should they be working on new things? And feedback has been pretty sort of discrepant in those ways. And there's also good theoretical justification for doing one versus the other, which I think then makes it quite interesting. And similarly, how do we deliver these targets each week? So I told you I'm really a firm believer in this empowerment and free choice, but what about the role of recommending things or assigning things? And certain people have actually said they wish we assigned stuff certain weeks. And so how do we deliver these tools? And again, there's theoretical justification for each of these kinds of sort of decision points. And so some of my next steps in my work is really wanting to then systematically test that through, through a micro-randomized trial, actually, to be able to sort of see what would be leading to proximal changes in clinical outcomes. And the other area I'm focusing on is better design within this line of work is better design for subpopulations. So in FoodSteps, we think about the role of negative affect and stress in relation to being sort of state level, but there's, I think, not good design yet for sort of big picture, capital S stress, in my way of thinking about it, like social determinants of health. So people with food insecurity, I'm part of a project where we're showing that people in response to racism are engaging in more binge eating. So it's not just what race you are, but actually being exposed to racism, both directly or indirectly, has led to binge eating. And how do we help sort of, address that in a tool for binge eating? But the broader vision, of course, is we assume, let's hope that FoodSteps is, the best intervention of all time. Great. Actually, how do we get it to the people who are going to need it and where they're actually showing up for intervention? And really, my broader vision is thinking about how would I implement this kind of a tool in the clinical settings where people with binge eating or weight management are presenting for treatment. And then specifically, I'm now going to turn to thinking about designing for implementation and the importance of integrating interventions into workflows. So to level set, to begin, integrating new interventions into existing workflows is challenging. Period. By design, it is just when people have an existing workflow, adding something new is a challenge. In my line of work in digital, I think that's especially true because the role of a digital intervention, particularly is designed to be different from in-person delivery. It's actually purposely designed to be distinct, which I think has added challenges for their integration into routine care. And there's a gap in knowing how, so the methods and techniques to implement digital interventions into healthcare settings. And so because of that, and sort of out of a response to being involved in a large implementation trial where we were trying to implement a digital mental health tool in a primary care setting, we were realizing that there just really isn't tailored strategies for digital mental health. So in partnership with colleagues, I led an endeavor to tailor the set of existing strategies that my colleague Byron Powell has created around the ERIC tool, and really then tailoring them specific to digital implementation, digital interventions, and how they can be implemented in healthcare settings, and trying to think through what are ways that we could actually tailor these strategies to best meet the needs of digital tools. And so I have an RO3 award where I'm actually applying some of these methodologies to FoodSteps, my app, where I'm thinking about sort of workflow plans, service blueprints, and the implementation roadmaps, meaning what are the strategies, adaptations, policy kinds of changes that we would need for the setting in order to implement FoodSteps in 3 different clinical care settings. So an eating disorder program, a weight management program, and primary care, and how we would sort of think about those workflows. And the reason I care so much about workflows is because for example, I think it's just an incredibly underexplored, but actually probably sort of, as John Toros and colleagues have really indicated, one of the most important factors needed towards facilitating implementation. And I'm going to now give you an example of where I think this is really quite important for our focus and where we have a whole lot of work to do for healthcare interventions and healthcare in general of implementing new interventions. And I'm going to give you an example from a program called IntelliCare, which is a digital mental health app for depression and anxiety. And my role has really been in this center circle is thinking about the role of coaching support and the product delivery model. And I was involved sort of in the first phase of an SBIR award, which is a commercialization grant in partnership with between academics and industry to implement the IntelliCare intervention in a primary care setting at the University of Arkansas for medical sciences. And it was the first trial where we were comparing IntelliCare to treatment as usual, but importantly for the field, it was also the first time where we were evaluating a mental health app platform and with primary care patients. And just to level set before I get to the workflow component is the results were great. So people who got the intervention over the course of the 8 weeks, their depression and their anxiety went down. And that was subsequently sustained for the subsequent 8 weeks, which was really the goal once you took away coaching. The people on the waitlist group, their first 8 weeks who were waiting to get the app, they didn't show much change in symptoms, but once they got the app, their symptoms then matched where people were at this in the intervention group. So that was really exciting. And in fact, one of the uniqueness in how IntelliCare is designed is really, again, around action over psychoeducation. It's really meant to be action oriented, and we see very high engagement in this tool. But I want to bring you back, and again, this is level setting for how it's then integrated into workflows. Thinking about, I mentioned sort of the importance of designing for the user experience. And essentially, I mentioned sort of the importance of not just how often are people using it or how much, but really what's their subjective experience in using interventions. And what we validated this, this theoretical model through using data from IntelliCare, where basically the objective use metrics were not significantly related to outcomes. And that kind of makes sense because often you sometimes want people to use it more when they're sick and you want people to use the tool less when they're doing well. But the subjective metrics were related to outcomes. So people who found this tool useful, easy to use, easy to learn, and satisfying had the more people thought that experience was positive, the more they saw reductions in their clinical symptoms. But so I told you that the trial itself, it was still a randomized trial comparing waitlist to we didn't randomize from an implementation perspective, but we did try to implement it and integrate it within the process of this healthcare system. And what we did is we employed lots of different referral strategies by which patients could then come to this trial and go to the tool. And I'm specific in saying come to the trial because it really wasn't just in routine care. There were steps in place to get people to come into this as a trial, but broadly speaking, we designed lots of referral approaches to introduce people to this tool. And what I want to spend time on is the EHR alert and order. And so basically we worked really carefully with clinicians, with IT. In fact, we had the head of informatics on our team, with a designer and lots of people to think about how we would actually build a workflow within the EHR where clinicians could make patients aware of this tool and refer them to the tool. And you can see this is a very busy slide of our workflow diagram and where the order would pop up in the EHR. And essentially, I think we found, and I love this picture, where interoperability with an EHR, best laid plans don't always play out how we think, and it is really challenging to do. And essentially, what we found is of the clinician referral pathways, so through the EHR alert and order, only 4% of patients who were referred to the tool came through that pathway. And to be clear, we spent a lot of time and money building out this workflow order in the EHR and ultimately had the lowest yield from that pathway. And also the penetration rate, I showed you this was a great trial. We met the aims and we had excellent clinical outcomes, but our penetration rate just from an implementation perspective was 13%. And actually that was higher than a lot of published mental health app trials in, like, it was higher than other studies in the literature, but it's still, I think a lot of us would say, not good enough, particularly given how sort of elevated mental health problems are. And so essentially, within the care cascade, I want to revisit our implementation strategies. And one of them is really this point about assisting with onboarding. And I'm going to just close the talk today with this point, which is to say, I think referral management is an incredibly challenging pain point and sort of the role of handoffs in the implementation cascade. And so I'm going to revisit that process requirement of where we say implementation cascade. So the point of first identifying someone with a clinical need and actually getting them into care and helping them stay in care, like that handoff process and assisting with onboarding, I think is incredibly it's a very high need. And essentially, when it comes to digital, in either way, whether it's digital or sort of a new healthcare intervention being implemented in a new setting, it's, who's responsible for getting this to people? What are the ethics and legalities around sharing information of patients and data sharing and endorsement from a care setting? There's a lot of components of this. And then, as I mentioned, specific with digital, I mean, there could be really pressing software integration challenges. And so I'm involved in a current trial, sort of the next phase of the SBIR, where we're actually trying to implement this suite in a healthcare setting. And we're collaborating with McLeod Health in South Carolina, a rural healthcare system, who is actually partnering with us in their very first time referring patients to a digital solution in their care setting. And I don't mean digital for mental health, I mean digital. And it's incredible working with them. And what we're spending a ton of time doing in our prep work is building out, and this is sort of a very simple schematic of it, is really building out our care pathways of how people are going to get to this tool. And so that we don't lose that and we don't have a low penetration rate. And so we've actually been thinking about sort of both the role of a referrer and then also adding in on-site support, where the hospital is the one who identified we'd like to really offer like volunteers and referral coordinators and individuals who are embedded in our system to help patients actually onboard to this tool, because actually getting people to download this app, from having symptoms to evaluating, referring them, to actually getting them to do and first engage with it, really is requiring sort of a careful planning and systems. And so to close, I want to sort of come back to, I guess, a more uplifting thing, which is to say we do have effective health interventions, that we have a lot of things that work, a lot of great tools for people. They're not widely implemented in healthcare systems and beyond. And successful integration requires designing these services to meet the needs of users and to really align with their implementation context. And to close, I think to really think about sort of this idea of designing for users' needs and designing for implementation context is really thinking through, I think, some of our big challenges in the time ahead is how do we think about designing interventions for all, and being aware of the ways in which certain of our interventions actually have affordances that might put groups at disadvantages. And in particular, as I mentioned, McLeod Health is in South Carolina, is a rural population. We've been thinking actively about the role of digital tools in rural healthcare. So for example, digital interventions have actually some affordances to how we think about care delivery that actually are not the case in rural communities, or could put them at distinct disadvantage if we don't carefully think about how these tools are designed. So the ability to fit services into the fabric of people's lives is going to be really challenging if people don't have consistent internet access. And so the ability to then have a tool that's more accessible, we need to think about the role of connectivity and the ability for these tools to operate offline, in addition to only needing to be online in order to facilitate use. Similarly, the role of these digital tools and being able to facilitate seamless remote patient monitoring through interoperability, well, that's really challenging when you don't have as robust of an electronic healthcare system. And of course, that's gaining more traction across different communities, but not everyone has the resources to build out sort of really specialized monitoring and sort of interoperability connections. And then finally, digital tools, as an example, can help reduce reliance on specialty clinicians. But in rural communities, we know that just the ability to have mental health clinicians in general is really a challenge. And so how do we think about making sure that we're designing digital tools for everyone? And similarly, designing for context. I think my work in partnership with commercialization companies has really, and in thinking about sort of implementing interventions in care systems, and in particular, really thinking about the role of designing for context from the start. As I mentioned, we're spending all this time with McLeod thinking about sort of what is the referral pathway, because if you don't get people in the door, the whole thing's dead in the water. It doesn't matter. And with that, it's really about, and this goes back to sort of these overarching design principles that I've applied in my work, getting things in front of end users quickly. So focusing on what are, and I use the term minimally viable products, but really sort of what are the core principles we need to achieve, and how do we test that with people quickly to learn, is that going to work or not? Or what are other ways that we need to be creative in thinking about how to get those kinds of core principles to help change people's behavior? And then of course, the idea and really embracing the need to iterate. And often our research trajectories don't necessarily account for the fact that things happen, and research in the real world comes with real world challenges, and we need to be prepared to iterate. And design thinking has been incredibly helpful in sort of imbuing the fact that, like, of course you're going to iterate over time. That's the whole model of what we're trying to do, and really imbuing that into how we then implement health interventions into different settings has also I think a strong need to embrace that iterative nature. And with that, I'll close.
Andrea, that was wonderful. We do have some questions, so I'm gonna kind of turn to the Q&A. Is it best to stop the screen?
I might stop the screen share.
Sure.
Cool.
So our first question from Jun Tao is, thanks so much for sharing with us this interesting project. I'd like to know your approach or the venues used to effectively collect users' feedback. And maybe, the IRB process for that, is it something that's collected pragmatically? How does that work?
Yeah, so good question. So both broad and then of course the nuances of IRB. So So essentially, I've tried to use a lot of different strategies. I do a lot of sort of individual, it's mainly qualitative. I found it a lot of help just doing qualitative work as opposed to doing as many like self-report questions. It ends up being a lot of really rich data. We've done it where it's basically I've used a tool quite a lot where people are able to give really brief snapshots, like a 30-second to 2-minute video in context. I actually haven't done sort of contextual analysis of that, but we do analysis of the qualitative responses. But what we're really seeing is people answering these questions about what's impacting their binge eating, for example, right in the context of sort of their day-to-day lives. So that's been one way in which we've tried to answer that question. Relative to over the course of the program, I am giving people who are then using the tool, FoodSteps, I'm giving them, surveys and things like that, but also trying to gather feedback through the coach, because we indicate this is still like in the pilot phase and we would welcome their feedback. But every single participant's then invited to do a qualitative assessment at the end that I lead, and sort of really asking lots of questions about their features and sort of what they liked. And more importantly, I tell them, what didn't you like? What can we do to improve? What more do we need to change? And just getting tons of amazing, valuable feedback from that. The IRB question's a fabulous one. I basically, sort of broadly speaking, sort of submit to IRB the whole bevy of questions I might want to ask as sort of broad strokes. And I indicate at the top, these are the types of questions that I'm going to ask people. The level of sensitivity will not change. What might change is sort of the specific questions we would ask. And that's been feasible through IRB, and they've been really supportive of that approach, where basically it's sort of, these are the types of things, but due to the nature of qualitative work, specifics might change. And so that's really given me the flexibility to say, like, if Ron, you were to say like, oh, I really like this feature, I didn't want to be limited in not being able to ask you follow-up questions to that. But so it has been a good balance in that way.
Second question is from Renad Batis. That was an exceptional presentation. I learned so much about this program of research that you're leading. I'm curious about the decision to use a BPA to integrate the intervention into the clinician's workflow. Did you consider other ways for integration that might utilize behavioral science principles like a default referral?
Yeah, amazing. So the answer is we did not at the time. And I think it was, this was a few years ago, which is not to say that we, point is, I think your point about behavioral economics and behavioral science principles is really spot on. And it's where, what are other ways that we could nudge clinicians' behaviors and being able to refer people? We were sort of at the time, it felt like, oh, this was the right approach. And I don't know that one of the interesting things that came out with the qualitative work with clinicians afterwards was not necessarily the challenge of that we had the alert. It was actually when in the workflow it popped up. So it was that because the way depression screening goes is sometimes it's an MA doing it, and then the provider, the doctor comes in and they might see the alert. It just was poorly timed. And essentially that I think also creates a lot of complexities of how do you design something that then is well timed, right? Like that's sort of tricky. And sort of the complexity of it. And I think that's where you're bringing up a great point of like, well, what if it was then default referral options? One of the things we're struggling with now, or I shouldn't say struggling with, we're trying to think through now is with McLeod, we want to make this so it's a referral option, just like you said, but then how does it create a queue where a different person, a referral coordinator, also gets pinged to be able to then know who they should sort of engage with in the session, but afterwards, like in order to help them download this app. So there's a lot of creativity we're trying to think through with that, and sort of how we can then design sort of within the EHR to then support that behavior change.
I have a question for you, Andrea. I think sometimes in my experience, the challenges for physician referral are not technological, but they relate more to something else you referred to, which is really the it's really the teamness of an intervention where you're referring to an outside interventionist or somebody outside the practice or outside my sort of trust circle is going to be delivering something. And part of it is I might trust them, but I don't know really what happens after I refer them, and there's consistent goals, or that we're on we're working towards the same. So yep. How does that work in the work that you're developing and in sort of developing this to be really coordinated across the different delivery settings?
Yeah, that's of course the vision. I think there's a lot to be uncovered with that. And I say that because to your point, so for example, with this work with IntelliCare, we want to design sort of report back. Sort of the whole idea is if we're actually then having people do an intervention, sort of the value for a care system is that they might get some details back that would actually help them inform other aspects of care. So if your patient does great by the end of the 8 weeks or whatever the delivery period is, amazing. And you might do one care pathway of like, okay, now I can do like sort of a watch and wait. If they're not doing well, sort of what would be that chain and that sort of referral back care coordination, how that's delivered, in what sort of, how often, in what medium, like some of the real specifics, I would say, of how to design that is very much up for debate and not up for debate, but sort of where I think a lot of our work is wanting to go. And then additionally, to your point is, with digital, one of the things we're running into is actually, and maybe this wouldn't be the case with digital or not, but sort of all of the ethics around the sharing practices. So who's owning this patient? And what you were describing, I think, is where you're saying I would own that patient, but other systems, it's like, oh, it's a referral management, it's sort of a referral pathway, like, and we're not owning that patient. So who needs to get the details back, and sort of really thinking through ethically and practically sort of where those data would go and who wants that information. It's a really interesting sort of next step. So currently with McLeod, we're actually thinking of sort of that front piece. How do we get people in the door? But the phase of work that we're really wanting to then subsequently go with that is then how do you sort of close that loop back with the care system? So I do not have an answer, but I think it's in a really interesting way, because it's exactly sort of the dream, right? You have these tools that can help people manage and conserve clinicians' time to then focus on problems like that are more pressing. But then how do you sort of close the loop with some of that? And I think there's just a lot to be designed around sort of the actual like practicalities of it. But welcome your thoughts if, yeah.
Yeah, the other thought I had too was that I thought was really great was the conceptual picture of the different ways people are getting to the interventions. That it's really about reach and engagement at a population level, and a lot of times when people do that, and I'm not suggesting you did, but that you see that 80% come through one pathway, only 4% come through. So let's go with the 80%. But the other dimension of that, of course, is that there are different types of people who self-refer versus people who require the physician to sort of nudge them. And I wonder if you're able to look at that and whether you're reaching different segments of the population through the different channels.
Yeah, so I don't mean to then have shown misguided data. Of that 4% that came through with the clinician referral, they had the highest rate of actually entry into the trial because they were sort of then appropriately picked. And so this was sort of who sort of first expressed interest based on the different care pathways, or no, excuse me, like got in. But anyway, I think to your point is we actually know when a clinician makes this recommendation to the tool, like that's incredibly powerful. And the other thing that came out qualitatively is it also opened the door. So by us having flyers in the waiting room, maybe that's how the person got in, but then they said to their doc, like, hey, I heard about this thing. And so a lot of patients were then initiating conversations with their doctor that they wouldn't necessarily have done otherwise. And it opened the door for doctors to have discussions that really extended beyond sort of what they might normally cover. So all of that's to say, I did not look at sort of demographically, like, is it males versus female, that kind of a thing. But we did then look at sort of more systematically, once you break those down, sort of where would you want to spend money? And I think to your point, it's like, I actually had tried to conceptualize a grant around sort of how do we think about different referral pathways? And it was hard to figure out the randomization of it all, but how do we think about that in ways that would empower clinicians to have the discussion so that we're better capitalizing on that, but while still like thinking about the fact that people need different ways to get in. And ultimately it might not just be one strategy. It actually might be a series of strategies that are most important.
Yeah. We have another question from Jaslyn Singh. Wonderful presentation. Could you describe more about your DTC model of engaging and recruiting participants?
Yeah, so admittedly, we sort of went for everything we could in terms of a direct to consumer approach. Like we just thought about, what are different ways to make people aware of a service. And this was sort of an interesting experience where it was, it's an NIH trial and we were software engineering took longer than we anticipated. So we were sort of under the gun to like really get participants in. And we actually like did this in an enormously impressive, I would say, fast amount of time as we got people in. So we were really trying to be as creative as possible of, what would be like sort of different touch points when a person shows up to a clinic that they could find out about this. So we actually, in the care system, they have a registry of patients. So we did some mailings to them because some people might want to learn about this, not by showing up. This was pre-COVID. We then had it in the waiting rooms. We had it in the elevators. We had it in the, I don't remember if it was in the actual offices, but in the office, of course, then we trained the clinicians and we had the best practice alert. And then we also did what we called sort of like campus buzz. So we had, a couple of like where it was being advertised sort of in presentations to the community, in newsletters that the hospital was putting out. And so there was all just different kinds of touch points that patients could come into. And I think, Ron, that gets at your question around like who's finding what, and it'd be a great thing to then sort of for us to look at next. But we were just more broadly just trying to understand like sort of how can we get people to learn about this? And because it was, I want to be very clear, it really still was a clinical trial. So we still had screening, consent, baseline, like there was barrier, like sort of hoops to jump that you wouldn't normally have in sort of a true rollout kind of an approach. So that makes it a little bit different.
Well, we're at the top of the hour. I want to say, Andrea, this has just been a tremendous presentation. It's exciting to see your work, and you have an infectious level of enthusiasm for it, and it's exciting to see. It also, it's really great to see the structure you put around evaluating the process of implementation and really optimizing the design to not just at an individual, but at a population level. It's really It's so relevant to many other areas beyond digital health. So
Thank you.
thank you for sharing your work today, and thank you so much for your presentation.
Thank you. This was wonderful. Thanks so much.
Bye-bye.